also with talking about, hello, back from the classroom mouse. We ended talking about amniocentesis and what's the other type of chromosomal genetic testing someone can do when they're pregnant. Anywhere from 7 to 8 weeks to like 16 weeks.
CDS.
CDS, chorionic villi sampling. There's a little bit higher risk, supposedly, with that than the other, than just taking the fluid, aspirating the fluid right out of the amniotic sac. If I flip back for just a second here, you can see we talked about different non-disjunction situations. Or was it?
It was the other.
No, it was the other way. I backed it up a little too far. Okay. So we talked about cloning. We went on to non-disjunction and different syndromes that result from that. Down syndrome, right? Turner syndrome or monosomy X. We talked about Klinefelter syndrome. We were kind of ending right around here. Yes. Okay. So the different types are amniocentesis and chorionic villi sampling. You do this at about 12 weeks plus. That's at about 7 to 9 weeks. Quicker turnaround time for the genetic results, about 20 days. Now notice, so one of you, I think it was Lex that you asked me about this last time, the testing and what you would do with this information. So you can do this at any point as a pregnant woman. You can ask, I want to have an amniocentesis. Maybe you have genetic or chromosomal syndromes in your family or genetic diseases, and you want to be able to test for those. So through the fluid, you can get blocked off skin cells from the fetus that can be tested genetically. And a karyotype, you can look at the chromosomes as well, like I introduced this lecture with. Chorionic villi sampling, you can do that earlier, and you're getting some tissue right from the chorion, from the developing placenta, which also has the fetal cells, so you can get the DNA. You can do this earlier. There is some risk to damage or puncturing of the limbs or parts of the embryo or the fetus. So that is a risk. Actually, I knew somebody that they had an amniocentesis, so they had this done, but the needle actually punctured the limb, the left front limb, and so he was a softball player actually in high school. We were friends, and his arm is shorter than the other arm. It stunted the growth and development of that arm, and that happened specifically through that. So it's not to say that these come without any risk. The risk is small, but it is there. So what would you do with this if you decided to do this as a woman and you want to know, does your fetus have any genetic or chromosomal anomalies? You would have that information, and what women could do at that point is whatever they want to do. If they want to continue with the pregnancy or they want to have an abortion. So when you hit about age 35, the doctors will ask you, do you want to do one of these procedures? In fact, they will encourage one of these procedures, or analysis by ultrasound, which they can measure levels of alpha-fetoprotein, levels. They can get estimates from those from the maternal blood. They can use ultrasound, size of the cranium, size of the spinal cord, and rump to cranium length to make estimates to see if there's any NTDs or other types of trisomies and different things they can assess. It's not as exact. This is more exact because it's genetic, but there's some risk. So you'll have that opportunity if you ever do get pregnant. At any point, you can choose to do this or you cannot. And for me, when I was hitting 35, having my last, I have a big childbearing span of my reproductive life. I started at 21, and then I went all the way to 36. So at 35, they were like, are you sure you don't want to do amniocentesis? Are you sure you don't want to do chorionic villi, one of these? I went, no, I don't think so. So I kind of went, nope, we'll just do the regular crown to rump length, then we'll do the AFP and the ultrasound. I'll just avoid that. I didn't feel the need, especially I felt like I would have to wait. You have to wait to get, more definitive results. You have to wait further in. So there are still sort of some issues and things that people have to juggle when they're dealing with this. But maternal age we will come back to later. It is a big factor in infertility, in miscarriage rates, in even, believe it or not, the incidence of twins. All of those, trisomy 21, all of those things go up with maternal age. There is one thing your textbook has in it, and it seems exciting, but people don't really do this. This is not so common. Oocyte genetic testing. They can go in with an aspirator, with a laparoscope, a camera, puncture through the abdomen, go right into the ovary, suction out the eggs, get the eggs, and analyze the eggs for genetic and chromosomal deformities or deficiencies. Look at the analysis of those eggs. And then those eggs can be used in IVF, in vitro fertilization, to do fertilization in the dish, and then reimplantation when the woman's ready into the uterus. or they can be frozen and for fertility preservation. Honestly, I don't know a lot of women that do genetic testing of the eggs. I don't know that this procedure is as common as doing things like amniocentesis or chorionic villi sampling. This is, however, a new thing now is fertility preservation for cancer patients. For women that are going to have radiation or treatment done to their ovaries or reproductive structures or anywhere in that vicinity, they will have the eggs aspirated out and frozen. And they can have them analyzed at that point if they want as well. You have to pay for that fertility preservation, of course, and to freeze them and do all that. So this is more commonly done with fertility preservation before radiation and treatment and all that, because that will destroy eggs. So someone after that would likely be infertile. So it's a way to preserve fertility. This wasn't done more than 5-6 years ago. Women, young women that had cancer were like, I don't want my eggs to be destroyed and my fertility to be gone because I have cancer and I have to go through radiation and chemo. So IVF experts and doctors and OBs started coming up with a way, okay, well, let's take the eggs out and let's freeze them, cryopreserve them, and then you could do it later. Yes? Okay, Jackie.
So I have a question, but it kind of like is a little bit off topic. So say like you freeze your eggs, and then like you decide you want a baby at 37. Does that mean you're at higher risk for it, or since the eggs were frozen, like if you froze?
Nope, good eggs because they're younger eggs.
Okay.
So a lot of times it's not the inability for the uterus to inhabit and have a pregnancy. A lot of times that is not so much an age-related factor, it's more the actual eggs themselves.
Okay.
The meiosis and the chromosome non-disjunction and the things that they start to become bad eggs. I hate to say that, but they start to become bad eggs with age. The more decades you go through life. Now remember, females, all the eggs are there from before birth in their little tiny ovaries. And they're halted in prophase 1. And then they resume meiosis, we'll look at pretty soon, we'll look at this on Monday. They resume meiosis when they ovulate. Some of those eggs could be halted and just waiting for 50 years. The average woman enters menopause at 51, okay? So they get wrought with more problems and situations. So an older woman could have a younger egg and typically be fine. Or can serve as a surrogate pregnant mother, right? So really it's an egg, it's a meiosis, it's an egg issue, and it's not so much a body issue in general. All right, we can do another thing though, and that is you can actually, if a woman is undergoing IVF, so if partners are doing IVF, they're doing in vitro fertilization where they got the egg from the woman, they got the sperm sample from the man, they put them together, they fertilize in the dish, you have a little ball of cells. Typically this is like at the 8-cell or 4-cell stage. One of those cells can be removed, and that cell can be genetically and chromosomally tested. These cells can still go on and form a baby. Remember, because these right here in the early stages are something we call totipotent. That means they have the total potential to give rise to everything, every other cell, including the placenta and the baby. This can be tested. Here's an example of what it really looks like. You have this little ball of cells, this little 8-cell. One is maintained with this little suction sort of capillary pipette, glass, holds it still while this other one has an aspirating tiny bit of suction, pulls one out. That cell can be analyzed. Typically there's multiple embryos. They'll do this on all of the embryos, and then they'll say which ones have a genetic defect or a chromosomal defect, which ones are good. The ones that are good, 1 or 2 will be implanted into the woman when she's primed and ready to go with for the pregnancy. So this is what we call pre-implantation genetic diagnosis, or PGD. I don't know if you guys have heard about things like gene editing. You've heard about like CRISPR and all the buzz around. We can send in these little molecular enzymes and tools and genes and go in and cut out specific disease genes or alleles. It's great. It has a lot of promise for being able to do genetic therapies and remove negative or diseased genes. And so there's talk, and already someone in China that was doing this and got in trouble, and a whole bunch of stuff happened with human embryos using CRISPR to gene edit embryos that have genetic defect, or they have a single gene genetic defect. I don't know if this is really going to catch on and go, because that's editing human embryos then, right? So it's removing a disease in some of these negative alleles, but it is genetically editing a human being in some way. So there's a lot of ethical, bioethical, and controversial things that sort of surround that. But I would just point out one fact for you to sort of consider now, knowing about this different types of genetic testing, we can already do pre-implantation genetic diagnosis. So as long as the individuals are going through IVF, say they have genetic defects or syndromes in their family, or they're having fertility problems, they're going to go through IVF. They can test the embryos genetically at that point, and then select and implant the embryo that's healthy or doesn't have the genetic defect. So in a way, we can select embryos, right? There's already some selection going on with embryos. Genetic editing would be more for, I think, has more applications for actual human diseases, where you can do gene therapy, things like sickle cell anemia, where you can cut out the negative genes from those blood cell genes or the hemoglobin gene and restore that individual and remove that disease that's already there. So that's sort of where I'm kind of thinking more about gene editing. So there's different types of genetic diseases, there's different types of genetic mutations. You don't have to know all these different types of mutations. It's just to show that sometimes you have a loss of sets of bases in DNA, or deletion, or a duplication, it doubles, or an inversion. That segment of the chromosome or the DNA flips upside down. There's some where you translocate, you have a piece of one chromosome and it ends up on another chromosome. This one was from 4 to 20. Lots of genetic mutations and changes can happen in the genome. And some of these are linked with diseases. Some of these are linked with diseases and deficits that go along with them. So now biotechnology has developed all kinds of amazing ways to detect even small little genetic mutations of a deletion of a base. So remember, DNA is made up of a bunch of bases, right? So you can have a whole sequence of like A, C, G, T, A, right? So we have ways now, there's restriction enzymes that can be targeted to specific sequences. Say there's a mutation here that turns this G into a T. And we have certain enzymes that can be very specific and targeted to certain alleles, certain sequences, where they will chop right at that mutation, if it's right there, right at that allele. And it'll make the DNA in different sizes, different pieces. So using enzymes, restriction, they restrict it and put it into certain pieces, along with things like DNA probes, where there's a little microwave, teeny little chip, and you've got little sequences on there that are basically probes that are like the opposite sequence that will bind to all of that DNA once you cut it up. If it lights up and binds to certain areas, we can target and look for very specific genes or gene sequences. But that's assuming we know exactly what the gene sequence is, or the causative disease gene allele or sequences, yes? So there's a lot, they're little tiny probes, they look just like this. All the probes are stuck to the microarray. You can basically treat the DNA, kind of cut it up, put it on the probe, and it can actually detect multiple different types of diseases. So you can do PGD, pre-implantation genetic diagnosis, treat the cell with enzymes, put it on a microarray, and look for very specific genetic diseases. And then that information is provided to the individuals, and then they can make a choice. Okay, so I'm not going to go over the details of these. This is in your textbook, and you really have to kind of work through this. I'm going to go through the 3 major types of disorders. But to do these family pedigrees, you actually have to kind of look through and go, okay, squares are male, females are circles, and if there's a diseased individual or a person with the defect, it's going to be blue. So in these cases, like, it's hard to see in here, but those are blue. This goes through how different genetic diseases are passed on, how they're inherited and passed on. In this one, it's an autosomal recessive. This disease it's an autosomal recessive, okay? So affected children can have unaffected parents. In this case, we've got 2 recessive. Recessive is usually a lowercase, symbolized by lowercase, and a dominant allele is usually symbolized by an uppercase. In this case, they have children, they have 2 girls. This girl goes on and partners with a male that's dominant, maybe a carrier, maybe not, has a heterozygous. Heterozygous means they have the recessive and the dominant allele, right? So one is the normal dominant, one is the recessive disease allele, so they have AA. If this female goes on with the male that is also heterozygous, notice that several of their children, male and female, will actually have the little a, the recessive, that actually is the gene for the disease. Okay, so it can creep up look 2 generations later. So in this case, the heterozygous individuals are normal. You can't see, they're called carriers. Carriers have the disease allele in this case, which is the little a, and it can be passed on to children, whether male or female. So let's see. Affected parents with homozygous dominant males will have unaffected children. Close unaffected relatives who reproduce are more likely to have affected children if they have a joint affected relative. So in this case, actually even too, there's relation here in these. This would be an example in Europe. This happened a lot, long time ago, even with like noble families and different people. They would marry cousins and different people, even siblings. Yes, it's weird. So autosomal recessive, if there's blending and familial kind of breeding and coming together, it increases the incidence of these diseases. Some of those examples of like hemophilia and different things, they're autosomal recessive. So the other type is, if we look over here, autosomal dominant. Autosomal dominant means the disease is carried, the allele that causes that disease is actually the dominant one. Okay, so it's the big A in this case. That is the disease causing allele, the big A. Now notice, it's hard to see, but that's blue, that's disease, that's disease, that's disease. Okay, so these individuals, and this one is too. Yep, right there. So it gets passed on quite a bit, and it stays in multiple generations, because that dominant allele predominates over the recessive allele that's non-disease. So if you have that dominant allele, that's it. The individual has it. They're not a carrier, they actually have it. You have to be little a, recessive, full homozygous recessive to avoid that particular disease. Okay, so I'm going to go over, there's another one, and this is actually comes up quite a bit, looking at male-female sort of diseases that run according to sex, and that's in X-linked disorders. That means, so remember the XX is on the female, the XY is the male. So X-linked disorders are actually carried on the X chromosome. Okay, so they're on the X chromosome. In this case, the disease one, this is an X-linked recessive disorder. That's the most common. So this X denoted with a little b means that's the disease allele. Okay, that's the genetic sequence that leads to a deficit in a protein or a problem that leads to the disease. So in this case, if you have the grandfather has the diseased X chromosome, has meiosis, has gametes, has offspring that result from those, and in this case, the normal allele came from the mother, the father gave the diseased allele. So in this case, this individual right here passed on that disease allele on the X chromosome. Over here, the daughter, because she has 2 X's, here's a son, here's a daughter. The daughter has the normal allele, which is the more common one, the big B, got the diseased allele, the little b, from the father. Now, the chances of her passing that on, she will pass it on to a son, more than likely, more than a daughter, because the daughters in this cases have 2 X's, so they have 2 chances to have the big B, little b, or have the dominant normal allele instead of the faulty allele, or the little b. An example of where we see this, and this is something that creeps up a lot, is color blindness. We also have male pattern baldness. That's another one. These are recessive X-linked disorders. They are carried, the gene is on the X chromosome, and it's recessive. But if that individual, right, is a carrier, like the daughter carries it now, if she has a son, she kind of has a 50-50 shot of passing on the disease little b to the son. So notice, if you have 2 X chromosomes, this is where females are kind of protected. Females are almost never colorblind. Males are almost always the colorblind ones. Okay? And actually can be as high as like 4%, 1 to 4% of males. Females are rarely colorblind. We've got 2 X's, females have 2 X's, so if I have the disease allele on one of my X's, my other X has the normal one. Then I have the normal dominant situation, so I'll make enough protein, I won't express that disease. But if I'm male, I only have 1 X, right? So if I'm male, I only have 1 X. So if I get the disease recessive allele, that's it. That's the one that's being expressed or not expressed. In colorblindness, they lack the color cones that allow us to see red, green, blue. Okay? And this is common. In physiology, I do tests. I do colorblind tests, and I almost always have 1 male that's colorblind. Almost every single semester. Yes? Yes? Michael? Colorblind?
Yeah, slightly.
He's like, yeah. Okay, interesting. We should get out my little color blindness test and do that in lab at some point. We could actually do that. We'll do that. I'll do that for you. It's real simple. You just have to do a little series of tests, and I can figure it out in like 2 minutes. Jada.
So is this like versions of like Punnett squares, but then like in ground floor down?
Yes. It's like Punnett squares, exactly. It's like Punnett squares, right? If you guys remember, you did a little bit of, you've got the, the little a, the big A, the little a, the big A. You put them together like 25%, 25, 25, 25. You just put that matrix together. That's the possibilities that those gametes can come together and make those offspring. And that's the likelihood that you're going to get, in this case, these different genetic disorders. So basically it's Punnett square, and it's just, these are family pedigrees where they actually mapped it out. Went, okay, these are the males that were born, these are the females. Here's how this disease traveled in that family. So if we go on here, this is right from your textbook, and it goes over some common genetic diseases, what they are, what chromosome that genetic defect is on, how common it is, and is there a DNA test available? For most of these, there's a biochemical and enzyme test or a genetic DNA test that's available using a microarray probe or enzymes like I described. There's things like cystic fibrosis, Tay-Sachs disease, Huntington disease, a neurological deficit, neurofibromatosis, sickle cell disease, so we talked about sickle cell anemia. This is on chromosome 11. It's just a change of one base, one amino acid. So it's a monogenic disease. Many of these, it's one specific gene that leads to that disease. Duchenne muscular dystrophy, so muscle wasting, degeneration of the muscles. Hemophilia, as I mentioned, the blood disorder, hemophilia A and B, a lot of bleeding, lack of blood clotting factor, it's on the X chromosome in this case. So is Duchenne muscular dystrophy, it's on the X chromosome. These, your book goes over in the very beginning. It opens with a story of a mom realizing there's symptoms of her little newborn baby as he becomes a toddler. He starts developmentally sort of going backwards, not progressing, has trouble swallowing, eating, moving, doing all those basic things. It's a neurological impairment, and it causes psychomotor difficulties very, very early. A lot of times it leads to blindness, seizures, and death. They typically die by about age 5. This is a disease, it's on one specific chromosome, it's one genetic mutation. So if you don't know, and there's no genetic testing done, an individual can be born with that, 1 in about 3,500, and it's very common in Jewish people and people from Eastern European descent. Tay-Sachs disease. And so, there are biochemical and genetic tests available to sort of detect that. So some of these cause early mortality, others people can live with them a lifetime, or they have reduced longevity. Yes, okay. This last part is just, there's a little excerpt in your textbook at the end of the meiosis and chromosome section. It goes into preventing and testing for birth defects. It summarizes all the things we talked about. How about eating a healthy diet? That's very important. So when someone knows they're pregnant or they're planning to get pregnant, they start considering, if they haven't yet already, good nutrition and healthier habits. Exercising, eating good, getting enough vitamins and nutrients in, avoiding things like alcohol, smoking, and drug abuse that can have really negative neurological effects and can result in birth defects, even smaller birth weight, cognitive and neurological defects. A lot of prenatal care from early on is really important. So it can affect a lot of different likelihoods of getting different congenital defects or neurological impairments that will happen from a far point on. Now notice though, a lot of the genetic diseases that we've just talked about, and a lot of those syndromes, those don't result necessarily from environmental exposures. Those are happening in the meiosis stage of the eggs or of the sperm. Or there's a genetic mutation that happened and it's genetically inherited. So there's literally nothing you can do about that, right? So this is to emphasize we can help eliminate birth defects and congenital malformations that can happen in a baby, in a fetus during development. But a lot of genetic and chromosomal things are unavoidable, right? So they happen, they're there. There's a mutation and it was passed down. So just read that, make sure if you haven't already, look over that. It's really interesting. What I want to sort of spend a minute on, and then we'll start the puberty section, going into sexual maturation. At the end of the chapter, it goes into this bioethical focus, choosing gender, Okay, and I mentioned this in the very beginning of the course. This was something I mentioned. I think a few of you went, okay, so I want to kind of come back to it now. This is an example of a couple. They actually did gender selection. Okay, so the questions I want to sort of address, you guys can talk with each other for a minute. Do you think it's acceptable to choose the gender of a baby? Why or why not? Now make sure you realize if you're doing IVF, you're getting sperm, you're getting eggs, you can select the gender, right? If you want to, there are places that'll do this. So what would that entail? Would we have to analyze the egg or would we have to analyze the sperm? The sperm. Because the sperm is carrying either the X or the Y. Y, is it as big as the X chromosome? Remember we looked at the big X and the little tiny Y? Y is way, way, way smaller. Sperm that are Y-bearing are way smaller and way lighter. So they can actually either sort of stain or centrifuge. Remember how we did the hematocrit? We spun them down, exploded the first time, then we got it to work right. When you spin it down, basically it can split out or striate the heavier X-bearing sperm from the lighter Y-bearing sperm, and then you can draw right from those two different sections. And it's pretty, sometimes it can be like 80-90% accurate in sex selecting. So then they would take the X sperm if they wanted a female, or they would draw from the Y sperm section of that centrifuge sample or treated sample, and then they would fertilize the egg and do IVF. So they would do in vitro fertilization and then implant the embryo into the woman. So I just want a couple of the questions for you to think about. Do you see any difference between choosing gender and choosing embryos free of genetic disease for having a baby? And sort of explain that. Do you think it's acceptable one day to genetically design children before they're born? So we're taking this from gender selection to physical trait selection. Yes? Okay. I would say talk to the one or two people next to you where you stand on these, and then we'll sort of talk as a group.
Yeah.